Now, how do we pick it up? So what do we have to do to catch this? Well, given the advances in modern medicine, we have a range of techniques that we can resort to. So I'll start off by simply mentioning the modalities. We have a barium swallow, endoscopy, CT scans, endoscopic ultrasounds, bronchoscopies, laparoscopies, MRIs, and PET scans. Now, barium swallow. Now, barium swallow might not tell us too much, but what it might show us is a tapering off of the contrast, often known as a shouldering sign. So this might help us differentiate it from other forms of dysphagia, which might actually be seen differently on this same imaging modality. For example, the corkscrew appearance that you might see in diffuse esophageal spasms, or the rat tail appearance that we find in achalasia. Endoscopies. So there is a reason I've highlighted endoscopy, and that is because it's actually the first-line investigation. This is mainly because it gives us a direct view of the tumor, and it actually enables us to maybe pinch a bit of it off and take a biopsy for it to be analyzed. And so once that biopsy sample has been taken, it can then be analyzed by the pathologist, which will give us more information as to what type of tumor it is, whether it's a squamous cell carcinoma or an adenocarcinoma. Now, the only limitation being is that the mucosal surface can be studied, and only the mucosal surface can be studied and biopsied. Although the advent of new endoscopes and the use of dyes might actually help us in the future. CT scans. The CT of the chest, abdomen, and pelvis can actually give us some clues about the extent of the tumor, as well as if it's invaded to other parts like the lungs, the liver, the peritoneum. Endoscopic ultrasounds. Now, this is actually a pretty nifty procedure. So basically, attached to the end of an endoscope, there's a little ultrasound probe, which is useful in actually telling us the depth of the invasion. So it'll actually help us stage the disease. And we'll talk about staging in the next segment, so don't worry about that just yet. Bronchoscopy. Now, this might actually show us the extension into the airway structures. And this is especially important for the tumors that lie in the upper and the middle third of the esophagus. Now, laparoscopy, it sounds a little drastic, but it can be used to identify peritoneal disease, intra-abdominal and hepatic metastases. And it's particularly important for the intra-abdominal esophagus cancer, intra-abdominal esophageal tumors. Now, MRIs are also really good for looking at distant metastases. It doesn't really have an added benefit over the CT scans, but it means less ionizing radiation, and it doesn't really require any intravascular contrast mediums, so you'd find that useful in patients who have renal impairment. Now, PET scans. Now, positron emission tomography. So this is a relatively new modality, and it's basically based on the metabolic activity of the cancer cells compared to the normal ones. So the patient is given 18-fluorodeoxyglucose, which is basically let's call it FDG for now. And when it enters the cells, it's phosphorylated. So that means a phosphate has been added to it. So let's call that FDGP. Now, FDGP can't be metabolized further. So therefore, it can't be moved out of the cells either. So it emits gamma rays, which are then picked up by a gamma camera. And then that shows us the hot spots, the things that you see on those TV dramas, Grey's Anatomy and whatnot. But in all seriousness, this is particularly useful when we are looking for liver mets. So that was just about the methods used in the diagnosis. Next up, we'll be talking about the spread and the staging. So stick around.